You said just now patient if history of abnormal behavior. Can abnormal behavior be the symptoms of meningitis or symptom of other problem? Does abnormal behavior include meningism? Or kalau if altered behavior, that one indicates signs where? Which part of your brain? Okay, so if the inflammation of your meninges, the signs that you have said earlier lah, irritability, fever, can be seizures as well.
Increase in ICP.
Not really. And then next stiffness, those are meningism signs lah. So if involve abnormal behavior, that one is not meninges already. That one indicate which part? If the infection involve your brain, we call it what? What we call it? Your brain tissue infection, we call it what?
Encephalitis.
Yeah, encephalitis lah. So encephalitis more likely to have abnormal behavior lah rather than meningitis. So you cannot put abnormal behavior as a sign of your meningitis. That's what I'm trying to say here. Okay, so does child have any abnormal behavior?
Just irritability.
It's very difficult to gauge abnormal behavior in small babies, like especially the infant, because their behavior is either crying. Okay lah, they can be encephalopathic, mean they're not focusing. Yeah, I mean they're not focusing. They don't know eye contact. Yeah, the 1 month old and above, they can have eye contact already, right? They can smile at you. Even encephalopathic child, even at 2 months, 3 months, mean they don't really look at you. They don't respond to you. Mean child is encephalopathic lah. Does your patient have that signs?
Less interactive, yes.
Less interactive lah, but they're still interactive.
Yeah.
Oh, okay. That's how is the GCS?
GCS is full when I examine. In ED, it's full as well. Then on day 2 of admission, lumbar puncture done. So glucose is 2.4. The ratio is 0.5. Protein is 0.81, slightly low. Leukocyte is 2.
Protein is how much?
0.87.
Okay.
Leukocyte is 240. Polymorph is 42%. Lymphocyte is 58%.
So interpret the LP result.
Yeah. So actually this one I'm a bit having. It's like a mixed picture for me, I feel.
What do you mean mixed picture?
Because the lymphocyte is 58%, right?
Okay.
Then the protein is 0.87. So usually if it's bacterial meningitis, it will be higher.
Higher what?
More than 1.
More than 1. Okay. What's the normal protein in infant 3 months old?
0.42 to 0.77.
So that one is not raised, is it? The point
It's
is
raised lah. It's raised.
So
But it's not like more than 1.
at what day they do the LP?
Day 2.
Day
So
2.
actually in ED they served antibiotics already.
Okay.
So it might result. It will affect the weight.
Not really lah. The biochemistry won't be affected so much with antibiotic. Only the lumbar puncture, so culture lah. So culture may be sterile lah if you send after the antibiotic. Okay, but the biochem will last 1 week, 2 weeks. If you do LP later on pun it's still about. It won't change so much lah. So based on your result just now, patient have evidence of meningitis or not from the self?
Yes, because the leukocyte is 240.
Okay, some more?
Appearance is clear.
Okay.
Glucose is low as well.
What's the ratio of glucose?
0.5.
Okay.
Stella.
Alright. So but it's LP, definitely the protein is definitely high. 0.8 is high already. Okay. This baby is not premature lah. If like
No,
0.6, 0.7, it's borderline lah. 0.8 is going to 1 lah. I would treat patient as meningitis for 2 weeks antibiotics.
But with this picture, it's more of bacterial meningitis.
No, but you have your polymorph there, you have your lymphocyte there. There is possibility of bacteria is still there lah. How much is polymorph?
Polymorph is 42%.
Okay, like it can be mixed lah. It can be part of viral also. One thing, but never mind. So since like protein high, white cell counts high, even the culture sterile, yeah, you probably want to give antibiotic for 2 weeks lah. Okay.
So
So antibiotic, what do you for 3 months old? What antibiotic you want to choose for meningitis?
IV benzopenicillin.
Okay. What is the dose? You should know the dose already.
100,000 units.
No. 100,000 what?
100,000 units per kg.
Okay. So frequency? What is high dose?
QID.
Yes, QID. Okay. Some more? Only penicillin.
No. 3 months.
Cipen enough.
No.
What else?
Cefotaxime.
Okay, so cefotaxime dose, how much? I won't ask this for medical student lah, but since you're a houseman already, you should know the common antibiotic dose because you're the one gonna start antibiotic. How much?
I'm not sure for cefotaxime.
Not sure. So okay, fine. Cipen, cefotax. Why 2 antibiotics? Why not just one? Cipen cover for what? Cefotaxime cover for what?
Atypical infection.
No.
Gram positive and gram negative.
Okay, so which one gram pos, which one gram neg?
Cipen gram positive,
Okay.
and then Cefox is gram negative.
Why not just gentamicin for gram neg?
Gentamicin, because the targeted bacteria is strep pneumonia and group B.
That one for Cipen lah. But why choose cefotaxime over gentamicin? That's the question.
Neisseria meningitis.
Why gentamicin? Why cefotaxime over gentamicin? What's the problem?
More broader spectrum.
Okay, but you're not answering the question.
Oh, not sure of that.
Not sure. So can gentamicin go to the brain or not?
Oh, the blood-brain barrier.
They don't go to the brain. So cefotaxime penetrate better lah. So you want high concentration of cefotaxime in the brain. However, Cipen cefotaxime yes cover gram neg gram pos, but once you have sterile, you have cultures come back, so you can off one antibiotic. So for example, if patient come back GBS positive, Streptococcus agalactiae, so which antibiotic you can show off? Cipen or cefotaxime? Cefotaxime off. Why?
Because it's gram negative.
Gram negative.
Got strep. Group B Streptococcus gram positive.
So you don't need cefotaxime already lah. You can give Cipen is enough lah. Okay. For 3 months old, they still use double antibiotic lah because they don't want to give rosufen because rosufen can sort of displace the bilirubin, so whatnot. So they don't really use lah. But for me, if no choice, can use also lah. Not much an issue. Baby 3 months old, they're not jaundice anymore. Okay. So rosufen cover for both lah, easier. Then is much easier dosing twice a day rather than QID. Okay, what are the complications of meningitis?
Infection, cerebral abscess.
So how do you know patient have cerebral abscess?
have to do imaging?
No,
brain?
but before you decided to do imaging,
Ah,
patient in ward,
ah.
what trigger you to order imaging?
Not responding to antibiotics, still having fever.
Okay. Some more?
Um,
Other than fever?
probably can repeat another lumbar puncture.
No lah, we don't do that. We don't do that. Yes, fever persistent. Yes, you suspect lah. Or fever already resolving, then suddenly spike again. Then you must suspect lah. Other than fever, what else? What are the symptoms?
GCS.
No, GCS can possible. Some more.
Raised ICP.
Can. What are the raised ICP signs?
Papilledema.
Can. Some more. One only.
Hip circumference.
Increase.
Increase in hip
Can.
circumference.
Some more. You've got enterofontanel. Apa lagi?
Bulging.
Can. Some more. But those meningitis also can have bulging lah.
Yeah.
Okay. Some more.
Neurological examination. Hyperreflexia.
So there's some deficit lah. What else? Increase ICP sign. What else?
Fitting.
Yeah. Fitting. Then what as you said earlier lah, reduce GCS also are part of. You said earlier reduce GCS and all that can be part of your increased ICP symptom lah. When you have several abscess, there is blocking in the drainage of your CSF, so you can get dilated ventricle and all that. So all those things can cause increased ICPs lah. Alright. How you manage? How you confirm?
Imaging.
What imaging?
CT brain.
So, patient got several abscess, then what's the difference between antibiotic duration? For meningitis, you give antibiotic for how long?
At least 2 weeks.
2 weeks, can be up to 3 weeks lah, 14 to 21 days, depend on the culture or whatever lah. So, kalau several abscess, how long you need to give antibiotic? Other than, okay, before confirm got several abscess, what you need to do? The next step of management. Drainage. So nak refer who?
Surgical.
Okay, can lah drainage or what. So kalau dia don't want to go in, cakap very minimal, then antibiotic.
Yeah, conservative.
So antibiotic duration gonna be how long?
4 weeks.
4 weeks enough
1
ah?
month.
Not enough.
1 month.
1 month not enough ah. Usually deep-seated abscess, how long we give?
2 months.
6 weeks minimum. Any deep-seated abscess, doesn't matter lah, liver, brain, lung, at least 6 weeks. Can be plus 2 weeks extra, 2 months. That's the duration lah. Okay, then patient discharge. Okay already patient discharge. What you need to do? Patient post meningitis treatment. You need to discharge to KK or you want to follow them up?
Follow up.
Where? Follow up where? KK or here?
Follow up in clinic.
So in clinic, what you want to see?
To assess for if there's any.
Macam buat a folder for the kena familiarize myself.
I see.
Follow up for developmental to see if there is any neural regression and hearing assessment.
See, Dr. Fawaz said cannot already. How? So neurodevelopmental assessment.
Yeah.
Okay, so complication they can have neuroregression or developmental delay.
Sorry.
Okay, alright.
I saw in protocol they say have to do neural assessment. Hearing assessment as well.
Of course. Why?
Is it due to like one of the side effect is it will affect the sensory neural?
Yeah. One of the complication of the thing lah, of the meningitis or cerebral abscess. Any insult to the brain, you still need to do hearing assessment, developmental assessment. Those two can be affected lah. So not just meningitis lah, patient come with HIE, apa lagi, any developmental delay or and all that, you still need to assess hearing as well. Okay, sekali. Alright, where's your book? So, can pass or not?
I think can too.